Hello. I recognize that this lighting is terrible, however, this angle is, also terrible. That's not the point. Dog? Hello, dog. Okay, I have to pet my dog while I'm recording this, otherwise she's not going to leave me alone. Okay, so, what you're about to see. You're about to see me doing a body paint of necrotizing fasciitis because I felt compelled to do something different. But also, I'm going to be kind of weaving in pictures of this particular case study, or at least whatever figures I could find thereof. Maybe some pictures of necrotizing fasciitis. We'll see. I haven't quite decided yet, to be honest. However, I will kind of be talking over the case study as well as reflecting upon how the way that they acted might differ from what's out there today, from what the body of research talks about with regards to necrotizing fasciitis. Whew, all the blood is rushing to my brain, so I gotta make this quick. I hope you enjoy. It's gonna be kind of a wild ride, and, there might be some bloopers at the end because, nobody who ever has done body painting has done it perfectly the full time. So, enjoy. I wasn't flipping you off. My first finger was just off camera. Okay, on to it.
The case study goes like this. A patient in his late 50s, let's call him Seb, presented with respiratory distress and hypotension at the chest pain unit. He had been able to walk into the hospital, but collapsed shortly after arriving. As the laboratory diagnostic suggested an acute infection, Seb was admitted to the hospital in search of concurrent infectious sites. Initial scans revealed that he did not have a fever and his white blood cell count was normal, but his platelet and hemoglobin levels were low. His electrolyte levels were within the normal range, but renal function was impaired. Of note, Seb was on immunosuppressive therapy because of an interstitial lung disease. Furthermore, he suffered from pulmonary hypertension, chronic hepatitis C, hyperparathyroidism, arterial hypertension, and a monoclonal gammopathy of undetermined significance. 3 years prior, he had suffered from pneumonia with septic shock, which led to acute kidney failure. After admittance to the hospital, a CT scan of Seb's abdomen and thorax was performed, and there was no evidence of an infection, but signs of excessive blood clotting were found. This led to an administration of an empiric antibiotic therapy consisting of daptomycin, clindamycin, and meropenem. During this short period of time, Seb developed skin lesions progressing on both thighs. He reported to have a skin biopsy on the left lower leg just several days prior to his admittance because of a suspicious mole, which might have served as an entrance portal for the bacteria. Skin lesions consisted of hemorrhagic bullae and skin necrosis, indicating necrotizing fasciitis and demanding the need for an operation without delay. The diagnosis was confirmed intraoperatively by necrosis of the fascia and later on by the analysis of tissue samples, which revealed Group A streptococcal infection. 2 hours had elapsed since admittance to the hospital. The patient was rushed into surgery, and a thorough debridement with complete removal of the necrotic fascia was performed on both legs through incisions medially and laterally, but amputation was not an option anymore because the disease had already spread to the abdominal fascia and his antibiotic treatment continued. Despite surgical intervention, the patient demonstrated progressive signs of septic shock. Surgical debridement was repeated 24 and 48 hours after hospital admittance, and during the last surgical intervention, necrotic tissue was no longer detectable. Despite treatment at the intensive care unit, the patient died of septic shock only 68 hours after admittance to the hospital. Now, let's reflect on this case study with the current body of research and determine what would be different today. According to Huey, Pasupathy, and Puvanendran, immunosuppressive drugs, renal failure, chronic disease, and peripheral vascular disease are all possible risk factors that can increase the chances of being afflicted by necrotizing fasciitis. Chen, Fasolka, and Treasy furthered this by saying immunosuppression and vascular disease place patients at a higher risk of developing necrotizing fasciitis with a progression into sepsis and toxic shock. Seb, unfortunately, with his chronic hep C, arterial and pulmonary hypertension, immunotherapy, and recent experience with renal failure, was at high risk for affliction and sepsis. With regards to diagnosis, even though this case study was published in 2013, not much has changed today. CT scans are typically used in order to detect inflammation by detecting a buildup of pus or detecting swelling. MRIs are useful for detecting the presence of gas, but both of these are more ideal when cutaneous changes have not been found yet, as they can cause a delay in diagnosis. According to the CDC, the truly gold standard of a confirming diagnosis is a surgical exploration by physically seeing and documenting necrotized tissue. In addition, a gram stain coupled with intraoperative tissue cultures can determine the causal pathogen. In Seb's case, cultures revealed that the causal bacteria was the gram-positive, toxin-producing Streptococcus pyogenes, which entered the body through the incision of the mole biopsy. Treatment options have also not really changed since then. Debridement of necrotized tissue is hugely crucial, which is the removal of any and all necrotized tissue seen. Although studies have difficulty documenting exactly how much time needs to have passed between the onset of the disease and the surgical intervention to maximize efficacy and the patient's survivability. That said, patients who underwent surgery 6 to 12 hours after admission had significantly lower mortality rates than those who did not. With regards to antibiotics, the goals are twofold. 1, reduce the number of bacteria, and 2, reduce the toxin production ability and activity of said bacteria. Thus, clindamycin is always used for its inhibitory effects against all toxin-producing bacteria, including Streptococcus pyogenes, but otherwise, broad-spectrum antibiotics are recommended, as no randomized clinical trials exist documenting empirical antibiotic therapy in necrotizing fasciitis. That said, adjunctive treatments have been proposed and studied, including intravenous immunoglobulins and hyperbaric oxygen therapy. Intravenous immunoglobulins is said to enhance bactericidal activity of serum by facilitating bacterial opsonization, neutralizing superantigens and toxins, or by making pathogenic bacteria more susceptible to phagocytosis. That said, while it has been used in a few case studies, truly conclusive evidence as to the efficacy of this treatment does not really exist, and the evidence that is present is limited to retrospective studies, case studies, or very small randomized controlled trials. Similarly, hyperbaric oxygen therapy has no randomized controlled trials to confirm or deny its effectiveness at reducing mortality either. Conversely, while intravenous immunoglobulins are approved by the FDA as an adjunctive therapy, hyperbaric oxygen therapy is not. Finally, let's talk a little bit about the disease itself. A group A streptococcal infection is a monomicrobial infection caused predominantly by Streptococcus pyogenes, although this infection can be secondarily caused by Streptococcus dysgalacti. Necrotizing fasciitis as a whole, however, can be classified by its causal bacteria or its location in the body. Back to S. pyogenes, this bacteria is a streptococcal bacteria that exhibit beta hemolysis on blood agar plates, belonging to the group A of the Glancefield classification system for beta hemolytic strep, thus giving the infection its name. According to the CDC, about 1,200 to 1,900 people die yearly from streptococcal disease such as necrotizing fasciitis, with a greater burden in developing countries where heart conditions are more prevalent. Fortunately, strep pyogenes is a gram-positive, non-spore-producing bacteria that has remained vulnerable to almost all classes of antibiotics, so it is generally not an issue to treat so long as it is caught fast enough, although it should be noted that in the case of necrotizing fasciitis, professionals are utilizing more broad-spectrum antibiotics to save precious time. To determine the identity of strep pyogenes as the causal pathogen, one would use a gram stain and a blood plate, identifying the bacteria as gram-positive strep, beta hemolytic with a clearing about twice to 4 times the diameter of the colony, white-gray, and dome-shaped. From there, a combination of a Lancefield antigen test and a bacitracin sensitivity test can be used to isolate strep pyogenes as a Lancefield group A antigen that is vulnerable to bacitracin. It should be noted that while some bacitracin-resistant strains of strep pyogenes have been reported in Europe, none have been found in the US to date. Alrighty, friends, that's what I've got for you regarding necrotizing fasciitis. What fun. Lots of gruesome pics, I guess. I hope you also enjoyed the makeup, because I really tried, guys. Anyway, right after this, there are a couple of bloopers that I hope you enjoy, and with that, good luck on the final, and I'll see y'all next time.
I have a lipstick that's the color of skin necrosis, and I stuck my finger in paint again. It wasn't as bad as it could have been, but it also wasn't as good as it could have been. It was a solid 75%, which is what I fully expect to get on this project. Could you imagine? My teacher looks at this and goes, "You're actually a circus clown." And I'm going to be like, "Yes! Yes, I am." Ooh, I made a terrible mistake! Okay, I corrected the mistake. Isn't she cute? I'm going to call her Melinda. Everyone say hello to Melinda. She's a lovely little hemorrhagic bulla.